Tim was having some computer issues, so he is trying to join.
I'm starting to wonder if we had an official, okay, get ready, get set, go, or if you wanted me to just start talking.
Let's give him just a second. I think he did want to introduce you, but if he can't do it, then he'll run back over here and tell me and we can get started.
Did they have the internet outage over at, yeah, I was at Callahan today, so I didn't know if that was everywhere or over there.
Yeah, everything's been really slow and intermittently working.
Hey, everybody. Sorry I'm late. I'm still having some technical difficulties with my work computer. So anyway, let's go and get started. I wanted to introduce Dr. Jason McKeown from the Division of Pain within the Department of Anesthesiology, who has graciously offered to come and speak to us about ketamine. So we're going to talk more about that at our town hall tonight, but wanted to make sure we had a chance for some education because I know it's a drug that many of us aren't terribly familiar with. So Jason, take it away. Thank you for coming.
What's the town hall like? What is that going to entail?
Well, it's our monthly staff meeting, essentially.
Awesome. I'm excited about talking about ketamine with you guys. Let me see if I can get this get the screen share to cooperate. Hopefully that looks the same for y'all as it does me. So, I mean, ketamine may be completely new for a lot of us talking about it here. I mean, it's new in the way that we're kind of launching this right now across multiple areas of the hospital that historically have not had it. It's relatively new. So I'm an anesthesiologist. I have a subspecialty in pain medicine, and I'm also boarded in hospice and palliative care. So I kind of work in a lot of different areas, and a lot of those areas are where we started using ketamine several years ago. The first protocol that we launched at UAB was in about 2014. We just barely got that off of the ground between 2014 and 2015. And then I left UAB and went into a private practice job in Memphis, Tennessee, where strangely enough, that group was also, it was a private group that was also launching a ketamine protocol in the Methodist hospitals in Memphis. So I went from working on the protocol, this long labor intensive process here at UAB, to walking into a program where we had basically just launched it there. And the reason it's so exciting to be talking to you about this is because I think ketamine is such a great advantage for a lot of our patients, and it's great for us to be able to use that as pain clinicians or anybody who happens to be treating a patient suffering from pain. Has a lot of different applications, and it was a huge success in Memphis as we rolled it out and as we used it more, and more people in the hospital became aware of it, and mostly in the surgical areas and in the post-operative areas. But it became kind of a novelty where a lot of nurses and a lot of people on the floor and surgical specialists were wondering what's this all about, to actually coming and seeking us out and saying, hey, that looks really great over there on general surgery. Can you do that for my patients? And so it's been just a real great advantage for a lot of places where I've worked. So let's talk about what we're doing with our ketamine infusions here now at UAB. Let's see. Next slide. I have no disclaimers. I have no financial relationships of any kind to report on any of this. Just our basic objectives today are just to discuss the indications and dosage recommendations for ketamine IV infusions, and talk about some of the potential adverse effects and contraindications, and then hopefully to understand monitoring and safety concerns about ketamine. Why ketamine? Who do we have set up to be able to administer it at UAB? Where can that happen? What are the doses that we're using? And when we talk about adverse effects, as I mentioned, and then move on to how we're monitoring patients that are receiving it. I want to overview some basic pharmacology in just a moment. The areas in which we're using, the patient populations where we're using ketamine are post-operative patients, as well as patients that are having pain and have maybe an opioid tolerance history, or maybe even opioid use disorder, these sorts of things that cause them to have opioid resistant pain, as well as patients that suffer from chronic non-malignant types of pain. Ketamine has a really, really colorful history. And strangely enough, it has, in a way, an origin at UAB that you may have never heard of before. But in the 1950s, we were looking, scientists were investigating other drugs that they could potentially use as IV anesthetic agents. One of these was, and they were exploring a lot of the different hallucinogen types of drugs. One of these was phencyclidine, which is also known as PCP, which is also known at Park Davis Pharmaceuticals as CI 395. And in the 1950s, they were looking at phencyclidine as a potential anesthetic agent. Realized real quick the problems that were going to be prevalent with that type of drug, the hallucinogenic properties, all these other types of adverse effects. Basically threw that out. But by 1960, they were kind of looking at some of the other derivatives of PCP, and were there some uses of these? One of them was called CI 581. And in 1960, Park Davis Pharmaceuticals started using this in some experiments. By 1965, a couple of investigators, one you see here, Dr. Gunter Corson, and Ed Domino was his partner. They were at the University of Michigan. In 1965, they had published a whole slew of papers talking about this novel anesthetic, or novel dissociative anesthetic called ketamine, or CI 581, and its usefulness. One of the interesting things I said, it had a colorful history. Dr. Corson goes back to World War II. Dr. Corson was a German tank commander, mostly in the the Eastern Front, fighting against the Russians. Dr. Corson wound up coming to America after the war, and as I said, he became a professor at University of Michigan. After that, he came to UAB as the third department chair of anesthesiology. So he's one of the pioneers with ketamine. And thanks to Dr. Corson, we have ketamine the way that we have it now. So by 1966, ketamine was patented and being introduced into clinical studies and uses in places like Vietnam as a battlefield anesthetic. And so those are the origins of ketamine. It's basic pharmacology, so it's a racemic mixture, and that's what we have that is available to us now. The S enantiomer, this is going way back to some fun oral organic chemistry, but remember that chiral structure, the S enantiomer is the one that is more potent in this case, but it is not available. What we have is a racemic mixture. It has been used some in Europe and used in some studies, but the racemic mixture is what we use currently for IV, for sub-Q, and PO, intranasal, and transdermal. All these routes of administration are possible with ketamine. It has been used in some studies in Europe. I'm not sure if it's being clinically used in Europe. To tell you the truth, I'm not sure of that right now. Some neurotoxicity has been shown in some studies when delivered as a spinal or a neuraxial anesthetic. So there are currently no NMDA receptor antagonists approved for neuraxial use in humans. We'll talk about NMDA in just a moment. The oral bioavailability of the ketamine solutions that we have is very low. Even the racemic mixture is 17 to 24% bioavailability. So PO intake is not a great route of administration because of first pass effect through the liver. It's one of its major metabolites is norketamine, which has a lot of nasty typical side effects of ketamine. The dysphoric properties and things like this are pretty common, and norketamine metabolite is responsible for that with use of oral ketamine. The risk of some of those side effects is higher than with the parent drug used in IV administration. It's very lipid soluble though, with a pKa near physiologic pH. Half-life is relatively short. It's got a low, not very well bound by plasma protein, and it is extensively metabolized by the liver and then eliminated by the kidney. You see there the demethylation process in the liver is responsible for the norketamine metabolite. Its primary action is as an NMDA receptor antagonist. It has some other activity at some other receptors, though, that you see listed here. Among those, opioid receptors, not necessarily mu receptors, but some of the smaller subtypes of opioid receptors like sigma receptors, and then dopamine receptors. You see between these types of opioid receptors and dopamine receptors may be the origin of some of the hallucinogenic effects that you can have in higher doses. Has some other effects, perhaps like local anesthetic has some effect on the voltage sensitive sodium channels. Indications for use in pain management. So again, I want to just stop for a moment and stress that some of the apprehension that I've seen in multiple places about ketamine is this idea that this is an anesthetic. And it is, but you have to remember this is a dose-dependent effect. So what has been advanced in the literature over the last couple of decades and in clinical studies is a low-dose sub-anesthetic dosing of ketamine. That's what we're using for our patients with pain. This is not an anesthetic dose that we're advocating or using on anyone outside of the operating room, where we may use it in a completely different manner. In pain management, we're talking about patients with severe intractable pain or pain that is unresponsive to opioids for whatever reason of tolerance. Perhaps acute exacerbation of chronic pain. Neuropathic pain responds quite well to ketamine, and post-surgical pain. Some types of malignancies, solid tumor pain from solid tumors and things like this responds very well to ketamine. Of course, a lot of times the patients that are being treated for cancer-related pain are very tolerant to opioids and are on very high doses. And so this is why ketamine works so well, because it bypasses the usual means, the usual receptor activation of the opioids is through the opioid receptors, and ketamine works in a completely different manner to produce analgesia. You may see ketamine used for other indications. We're not focusing on status epilepticus right now, or use in moderate sedation or as an anesthetic in the operating room. These are outside the scope of this talk right now. So why would we bother using ketamine for pain when there are so many other agents that we're so much more familiar with? But really over the last couple of decades, as we have seen the opioid crisis in the United States and really all over the world kind of mushroom out of control, we have realized that we still need to treat pain. And we realize the risks of using opioids, and that there are ways that we can use other multimodal agents to kind of curb the use of opioids in a lot of areas. And so ketamine is a great example of one of these, a very potent drug that is not an opioid and can be used very successfully to treat pain. So this is one of the reasons, but that's also kind of what's driven it in our hospital is the need to look for other ways. We've got opioid stewardship focus, some interdisciplinary group that meets and talks about ways that we can be responsible with prescribing and treating patients with opioids. And so one of the best reasons, I think, or one of the best ways that we can do that is judicious use of ketamine for a lot of our patients. As I mentioned, we're talking about a continuous low-dose sub-anesthetic infusion of ketamine. And what do I mean by low dose? And you see the bold face at the top of the slide. It's a very small dose. And what our protocol calls for is dosing of our ketamine infusion based on ideal body weight. 0.1 to 0.5 milligrams per kilo per hour, ideal body weight. How many of your patients around UAB do you see that are ideal body weight? And mine in the operating room, we are challenged by that. And so by the time you take younger, healthier patient, perhaps, who is very tolerant to opioids, I can assure you this is a very, very conservative dose to start anyone at 0.1 milligrams per kilo per hour ideal body weight, with sometimes between 5 and 10 milligrams of ketamine per hour. It's a very low dose. By contrast, when we use ketamine as an anesthetic agent, has all those side effects like dissociative anesthesia. The patient is unconscious, they lose airway reflexes, they hallucinate, salivate, hypertension, all those sorts of things we're going to talk about a little bit later, is due to a much, much higher dose, magnitudes larger, and you see it here in the right-hand panel. That's a dose of 2 to 4 milligrams per kilo in an IV bolus. This is hundreds of milligrams given at one time in an IV push. So you can see there's quite a huge difference between that type of dosing and the dosing that we're rolling out across the hospital, formerly to our ICUs and PACU, and now to well-trained floors, inpatient floors with regular monitoring. So 2 different things. Mechanism of action, as I mentioned, the NMDA receptor is found in the central nervous system, and its main neurotransmitter that acts on that NMDA receptor is glutamate. Glutamate is the bad guy in a lot of scenarios, including opioid tolerance and opioid-related toxicity and hyperalgesia. Glutamate is upregulated, and the NMDA receptors are super sensitive to those to the large amount of glutamate neurotransmitters. So when you have an effective NMDA receptor blockade with ketamine, this is why it becomes so much more effective, reversing that opioid tolerance and hyperalgesia that you may see. It has been described as resetting the opioid receptors in patients who are opioid tolerant. This effect is very rapid, with onset given with an intravenous dose. We're talking about an onset of 30 seconds, duration 5 to 10 minutes. Mentioned the metabolism and the elimination, but move on. Again, I'm really trying to drill into that. I think I put that animation in there later, but hopefully that that reinforces that idea that we're talking about a much different dosing protocol for pain treatment. So just a diagram of NMDA receptor pharmacology and what that looks like. As I mentioned, that glutamate induced neurotoxicity is attenuated by blockade of that NMDA receptor, which effectively attenuates and reverses the development of tolerance to opioids. So who can administer ketamine? Our nursing education has been a big component of the rollout, and that being that having been finalized and established in health stream modules called Ketamine for pain management. This is available for all nursing areas now, so it's a prerequisite for nursing for administering and monitoring of patients who are receiving IV ketamine. So all of those policies related to ketamine administration are out there and public now for our nursing partners. Who can order ketamine? Well, the primary physicians in the critical care units, and then for the acute care units, the other units outside of critical care areas, it's going to be the inpatient pain service, where we may get involved with you and with your patients and whatever areas they are being treated would be through consultation. And if we deem that a patient is appropriate for ketamine, or you identify a patient that you think would benefit from ketamine, and through a consult with us, we can order that for them, and we can start that infusion on for your patient in a 4-bed area. Just to reiterate, so the ICU, PACU, palliative care unit is one of the earliest areas that we've treated patients with ketamine infusions. The ED has been using ketamine for a few years, I believe, and now we're advancing use of IV ketamine infusions to all nursing units that have completed the initial and annual education. Again, the sub-anesthetic dose is 0.1 to 0.5 milligrams per kilo per hour. Our initial dose usually starts at 0.1 or 0.2. As I said, it's very conservative. We up titrate patients quite quickly most of the time. Some of our older patients, surprisingly, will get a really strong effect, a great analgesic effect with no side effects, with even a 0.1 dose. So at 5, 7, 10 milligrams an hour, these patients are getting great relief. Some younger patients, maybe the ones that we were talking about, maybe with cancer pain, acute on chronic pain, opioid tolerance, opioid dependence, we quickly titrate them to that 0.5 kind of dosage. And sometimes they still need very, very large doses of opioids in addition to this. Continuing on about some other critical ideas, but about polypharmacy. Sedatives and analgesics really can only be ordered by the primary team, IPS, or the palliative care physician because of the synergy that we get between ketamine potentially in some of these other sedative types of drugs. Oral ketamine as well is going to be restricted and must be approved by palliative care or IPS. That is mainly because of it's a little bit of a more complicated dosing protocol, and it's a bit more complicated as far as side effects and things like that. As I mentioned, the metabolites are commonly implicated for that. Ketamine in and of itself, though, doesn't require end-tidal CO2 monitoring. Why is that? Because the CO2 response curve is not altered. We're not talking about an opioid. This is not a drug that depresses the respirations or respiratory drive. One of the things that made it a beautiful kind of anesthetic when the early investigators were looking at this was one of the biggest usefulness, or one of the most useful properties of ketamine, is that patients continue to spontaneously breathe and breathe quite well, despite being anesthetized with ketamine. So you can imagine why it might be really, really useful as an anesthetic in a battlefield environment like in Vietnam. Ketamine is only administered through a dedicated IV line, so you can't piggyback it with other infusions. There have been some rare incidents of precipitation in the line, since this is such a slow-moving infusion. You can have it precipitate with some other drugs if you have them piggyback, so you can't do that. It must have a dedicated IV. Nurses also always concerned about titrating it, and this idea of maybe they inadvertently overdose a patient, but nurses are not going to titrate ketamine infusions independently on acute care units. Nurses will only change the infusion rate as ordered by an MD. So there are no titrate to certain parameter kind of orders. It's only by specific titration that we might do on rounds a couple of times a day. A second licensed nurse is going to co-sign, and this has to do with how the drugs are delivered and dispensed and things like this between pharmacy and nursing, and it's important as well for safety to have that patient on fall risk precautions. Vital signs for ketamine are per the pain assessment policy in the hospital. Be done every 4 hours. Other than that, nursing can refer to Lippincott procedures for pain management. All right, a lot of words on the next couple slides. This is getting into kind of the maybe the meat of the discussion for clinicians that are unfamiliar with what these patients who are receiving intravenous ketamine may look like, or what they're going to do, how they're going to respond to it. But these patients, as I mentioned, when we launched this Methodist hospitals in Memphis, the patients look great. And this is why we had so many surgeons coming to us saying, hey, can't my patient get ketamine too? You think this is a good patient for ketamine? Because more than likely, the patients are going to be more alert. They're going to be interactive and participating in care, having normal conversations, and more mobile than what you're probably used to with patients that are getting conventional analgesics and opioids. At the prescribed dosages for pain, as I mentioned, ketamine is not going to cause respiratory depression. They may even have profound analgesia, but they're going to keep their eyes open, have all their reflexes intact. They may have some mild pupillary dilation. Nystagmus is quite common. Patients can sometimes have some amnesia after they've been on it for a while. As far as other pulmonary effects, bronchodilation is a common effect and a known effect for ketamine that may make it advantageous in certain pulmonary populations. Some of the adverse effects that we're going to be looking for as we're titrating this and deciding if we have reached optimum dose to maintain good analgesia without, going over and above and causing problems. But quite common. Actually, some of the most common effects are going to be dizziness and diplopia and headache. So the patient is, may have all the appearance like I just described just a moment ago. Pain is well controlled. They're awake. They're eating. They're having normal conversations, but complain of maybe feeling dizzy, maybe have a dull headache or some double vision. Those are all very, very common. So while I may say adverse effects on this slide, it's common enough that it's really not a problem. Increased secretions and salivation can be noticeable sometimes. Sometimes behavior changes, just maybe some odd types of affective changes. Fainting and palpitations, as much as we talk about things like this, I don't think I've ever seen after using it for many years. Some involuntary muscle movements I really think is quite dose dependent. I've never seen that at all with low dose infusions. Maybe some mild anorexia, maybe nausea. I've seen that once or twice, but these were on patients that were receiving maybe the higher limit of the infusion, maybe on opioids as well, or have other reasons to be nauseated. And finally, severe allergic reactions, anaphylaxis are extremely rare. And those types of allergic reactions are going to look like any other anaphylactic reaction. So just to reiterate, headache, dizziness, diplopia, some nystagmus, those things are quite common. Rarely a problem though. Potential adverse reactions that are cause for concern and would cause us to either down titrate, reduce the dose, or stop the infusion altogether. And this is something I should stop and say right now, that any clinician, any member of the care team that's is participating in the care of this patient can stop this infusion. So if the IPS is directing a ketamine infusion for a patient on your floor, and maybe at some point during the course of treatment, some of these warning signs become obvious, that infusion can be stopped by anyone. It doesn't have to go through the IPS. It's treated as an urgent intervention, and we can revisit that. If it's some of these milder effects and things, we can always talk about it and maybe reduce the dose. That usually takes care of the problems. Bothersome side effects almost are always treated by just reducing the dose, and that takes care of it. Overdosing, though, can cause anxiety, confusion, combativeness, that dissociated kind of feel, the out-of-body experience, hallucinations. Mentioned the salivation and the other sympathetic stimulation that can lead to tachycardia and hypertension, even increased ICP. All these are, as I said, very dose dependent. They're problematic. You don't see them. I can't even remember the last time I've seen any of these sympathetic types of effects on patients that were receiving the low dose infusion. Really, those are with big boluses when we're using it in the operating room. Unfortunately, there's no reversal agent. There's no naloxone or anything that you can give for ketamine overdose. So basically, we're going to stop the drip in the case of any of these kinds of warning signs or these severe adverse reactions. We're going to stop the infusion, contact the ordering physician, especially if any of the following occurs: a RAS score of less than 3, systolic greater than 180, less than 90 O2 sat, respirations less than 8, development of muscle rigidity Confusion, delirium, I say bothersome dreams or hallucinations. You can put a lot of things in the category of hallucinations. I think most of the time when we say people are hallucinating on the low dose that we use, the hallucinations are usually maybe some, kaleidoscope kind of effects on the ceiling, maybe, some of these sorts of things. They are rarely bothersome. And when they are, they're usually treated quite effectively by turning the dose down or by use of small dose of benzodiazepines or even Haldol for severe reactions. So vital signs typically monitored, all the usual monitoring per pain assessment protocols. Big thing is to just pay attention to mental status. Are they alert? Are they oriented? It's usually real clear when they are hallucinating to some extent that they're really bothered by it. As I said, you treat most of these symptoms though with small doses of maybe Ativan or Versed, maybe Haldol. But remember, use of benzos with ketamine may prolong the sedative effect of ketamine. Some thoughts about oral ketamine. Again, we're using it for moderate to severe pain, often opioid tolerant types of pain, neuropathic pain, severe postoperative pain. But adverse effects, I mentioned a couple of times, are due mainly to those metabolites. So maybe drowsiness and confusion, all the things that we talked about in the last few slides as far as adverse effects are going to be more common with PO ketamine. Really only the inpatient pain service and palliative care are going to prescribe or recommend PO ketamine. And we don't do it all that often, to be quite honest. If you have questions regarding administering ketamine for pain management, we want you to speak up. We want to make sure this is an open dialogue about it, especially as we're kind of advancing it and trying to use it more frequently through the hospital. If you see problems, you have ideas where we can be safer, where we can treat our patients more effectively. We want to make sure we're all talking about this. So talk to the IPS or nurse management, anybody else that's involved in this this rollout, maybe with the opioid stewardship committee. That's the end of these slides. The rest of these are some other pieces of information not really pertinent to the discussion today. I would love to take some questions if you guys have them.
Are there any specific tachycardia syndromes? I feel like I was following a patient, I think an orthospine patient on it, who developed new AFib with RVR that we were having a difficult time managing, and then stopped the ketamine and it seemed to resolve. So it seemed like there was at least a temporal relationship with the medication. So specifically arrhythmias or just kind of any kind of tachycardia that we could expect to see?
Yeah, I think the main effect is going to be a sympathetic activation, and it's hard to be specific to the type of rhythm that may be generated by that. But I'm like you, I feel like AFib is one of the more common presentations. If I recall, it's been a while since I've seen anybody that did that, but I feel like that was the scenario. It was an older patient. Maybe they had some episodes of paroxysmal AFib anyway, but certainly if there was a bit of a sympathetic overflow related to the ketamine, then that was going to be the way that it presented. But I don't know that there's any specifically associated rhythm. I don't think that there is.
Does use of ketamine raise any concerns, especially with the documented effects of patients having amnesia. Is there any concern about patients' medical decision-making capacity, or, between that and like some of these altered sensorium type pictures, have there been any concerns around that?
Yeah, just I think it's enough of a concern that you want to maybe wean the patient off, to have them off of that before maybe declaring a change in code status or those sorts of things. That came up just recently with a consult that we had. The patient was very, very clear. I mean, there was, and then the question comes up, how long do you have them off of it, to say they are officially cleared from any kind of amnestic effect. I don't know that you can really say that, but I'd say within 24 hours, this patient was extremely clear and concise about what she wanted and, the direction of her care and everything. So I think that is a concern, but again, it's easily managed by weaning them off of the ketamine, I think.
I have a question. This is Carla Williams. Thank you so much for giving this fantastic talk. I actually had a patient that I was considering beginning ketamine on today, and still in the process of considering it, who had a BKA and is experiencing a lot more pain than what I would expect. And we have determined with psych that there is some psychosomatic components to the patient's pain as well. I guess one question that came up in my discussion with IPS today, that I'd like to get kind of your opinion on, is how often we actually see mood lability with these patients, and is ketamine something that we would need to seriously consider avoiding in patients that have underlying anxiety that may be exacerbated, or PTSD that may be exacerbated by procedures like limb loss?
Okay, there's a couple of great things there. I think for sort of the mixed presentation that you get, because amputations are so difficult to control post-operatively, and some of them have so much more pain than others. You're right; it can be kind of a mixed presentation, but between the somatic and the neuropathic components of that pain, ketamine works really quite well in patients that are not getting enough control with opioids. I mean, it just it's a great choice. I feel like the affective or behavioral changes that you see with the low dose infusion are not very prominent. I would say it's maybe noticeable if you titrate to those upper levels of infusion, but anecdotally, the lower doses, it's not really problematic. Now, if they have pre-existing anxiety and depression problems, I think it's even better because of some of these other effects that it may have between NMDA receptors and some of this SNRI types of effects that you may have from it. So this is one of the great reasons that it's been investigated for refractory depression and suicidality in some patients. So anxiety, depression, I think ketamine's an even better choice. And just kind of on the horizon right now, we anesthesiologists and anesthesia care team members have historically avoided ketamine in patients perhaps with PTSD problems, maybe like veterans. Veterans are the very ones driving some of the investigation, the studies that are going on now between ketamine and some other of the typical the other hallucinogen types of psilocybin, and these types of psychogenic types of drugs are being investigated and look like they may be very, very useful in some of those populations. And so that is that's still to be determined. But since you mentioned PTSD, that's what it made me think of. That may actually be an indication for it sometime in the future.
Has there been any discussion about using ketamine for sickle cell vaso-occlusive pain patients?
Yeah, we do have some experience with that population around UAB. Our hematology colleagues do a wonderful job with PCA management and everything. But even some of the patients with a well-managed PCA have enough opioid tolerance, and their pain is such a prominent feature of their crises that opioids just don't cut it for them. So we have been involved with some of those as consults, and they do well. There's not a lot of literature, I think, out there that says ketamine is absolute go-to drug for sickle cell crisis, but there are good case reports, and anecdotally, I think it's very useful, and it's just because I think opioid refractory pain responds so well to ketamine.
Any other questions?
Do you know if y'all are looking at or tracking the length of stay on patients that you're using ketamine with? I've just heard a couple of like anecdotal reports from some of the neurosurgery whatnot patients that they felt like patients are staying here a little bit longer. Do you know if there's any truth to that or if anyone's monitoring that?
Our team is not monitoring it. I'm trying to think neurosurgery. We have a protocol where we manage ketamine for ortho spine. So I'm curious that neurosurgery says that, because right now I don't think we have any of the neurosurgeons on board with that protocol to have them complain that their patients are staying in the hospital longer. If anything, I see more of their patients who we are consulted on, who are having a lot of uncontrolled pain after these huge spine surgeries, that we wish they would use ketamine for their patients, but they don't. The orthospine patients, I don't think that it's holding anybody in the hospital longer. Again, it's anecdotal. I don't think anybody is tracking any of this. At least no one from our service or anything is tracking these consults. But I'm interested. The few patients that we are treating with IV ketamine on neurosurgery, I'm curious who is saying that the patients are staying in the hospital longer.
It's probably a mixed bag because it was the UNSN unit that specifically mentioned that recently. So I didn't know, but it's probably a mixed bag of ortho spine and neurosurgery.
Yeah, orthospine, they do go to UNSN, and that's the area we have typically been taking care of the orthospine patients over the last couple of years. But we're shutting those drips off a lot quicker than I think a lot of times the patient deserves. So I can't see from a consultant perspective that these patients are staying in the hospital a lot longer on ketamine. If anything, it's like the next day they're still hurting. It looks like a lot, and the primary team's going, "Okay, get rid of the ketamine. We're done." And so, yeah, I don't know. That's an interesting observation to me. Does anybody have any other concerns about monitoring or adverse effects or anything like that I can address any of those types of anxieties for you? I appreciate it. There's yeah, I'm glad for the opportunity. We've had a lot of success with it in the short period of time we have used it here. And as I said, other institutions already are using it much more widely, and it's been well received and successful the other places where I've worked anyway. So I look forward to working with more of you on it.
Well, thank you very much, Jason. We really appreciate you coming and talking to us. I'm sure we all learned a ton. So we appreciate it.
Okay. Appreciate you guys. Thank you.
Thank you.